So good morning, everyone. This is Dr. Jonathan Fleur-de-Lis. We're here to discuss about hand and orthopedics, hand surgery and orthopedics. Now, for today's topics, we're going to talk a little bit about the anatomy and biomechanics of the hand, just a little tiny bit of physical examination. We're going to talk about the degenerative disorders, nerve entrapment syndromes, bite wounds, infections, trauma in pediatric conditions. Now, I would like you, in your own time, to review the anatomy of the hand, because that's not part of the scope of this lecture. Basically, look at the phalanges, the metacarpals, and the carpal bones. Also, I'd like you to look at the ligaments and tendons, especially the compartments of the extensor retinaculum. Now, this is the extensors and the compartments 1, 2, 3, 4, 5, 6. I would also like you to check the nerves that go into the hand, which are the median, radial, and ulnar nerves. Of course, there is some intrinsic musculature inside the hand, and they are mainly innervated by your ulnar nerve, the abductors and adductors. The sensory distribution of the hand now is very important to know. The thumb, along with the index, the middle finger, and half of the ring finger are innervated by your median nerve. The last 2 digits of the ring finger and the pinky are innervated by the ulnar nerve, and everything on the dorsal surface is radial. And these are the physical examination techniques that you can use, not just on adults, but especially in children, to check the integrity of the median nerve, which is a fist. The ulnar nerve is a peace sign, and the radial nerve, which is extending all the digits like a high five. So, to assess the neurologic status of the upper limb, you can do that really quickly. Finger flexion or forming a fist is median. Radial nerve is extending all the digits like a high five. And the peace sign is the ulnar nerve. And you may even check the AIN, which is the anterior interosseous nerve, by forming an OK sign. This is for usually supracondylar fractures. Now, as I mentioned, starting with the median nerve, a common entrapment syndrome, and this is at times work-related, is the carpal tunnel syndrome. Now, what I'm going to show to you is why, with a lot of work, if you're overworked, you may have a carpal tunnel syndrome. So if you keep on using the dominant hand, you have more energy and use of the muscles. This actually entraps the median nerve in between the muscles and the transverse carpal ligament. This will lead to what we call the carpal tunnel syndrome. Now, the other things that can cause carpal tunnel syndrome are poor ergonomics, poor posture, use of power tools such as a drill, repetitive trauma with a jackhammer, using a hammer, or power tools in general. That can cause, or those are some of the risk factors for carpal tunnel syndrome. And this is eventually treated with an open carpal tunnel release, especially if the patients don't have any time for rest or relaxation, if they don't have time to do physiotherapy, rehab. So continuing with carpal tunnel syndrome, you have to know the anatomy of the hand. You have to know where the median nerve is in relation to the transverse carpal ligament. And if you're looking at the ulnar nerve, because you have symptoms in the last 2 digits of the hand, which are the ring finger and the little finger, you may be looking at Guyon's canal. So know the relevant anatomy in the wrist. You'd also like to know how the nerves enter the wrist into the hand and what they innervate. For severe carpal tunnel syndrome, a patient can actually present with thenar atrophy. Okay, so usually the dominant hand has a lot of muscle, but this time the dominant hand, especially the thumb muscles, are gone. That's thenar atrophy. It can be caused by a nerve impingement syndrome in the cervical region or a carpal tunnel injury, or even both. When you have both, it's called a double crush syndrome. You have a problem with the cervical spine. You may also have a problem with the wrist or both. So what are the tests for carpal tunnel syndrome? You have the Phelan's test, which is to flex both wrists, and you have symptoms of tingling and pain and shock-like feelings into the first 3 digits and 1/2 of the ring finger. You can do Tinel sign, okay, hitting or tapping on the median nerve at the wrist area. That will produce the symptoms again on the first 3 digits, including 1/2 of the ring finger. And the most sensitive test is actually the carpal compression test. So you do this compression test with moderate pressure on both wrists for about 1 minute. And usually in 20-30 seconds, the patients who have carpal tunnel syndrome will feel those sensations going through the first 3 digits as well as 1/2 of the ring finger. Now you can also test this objectively with an EMG and CV, which is electromyography and nerve conduction velocity tests. The treatment in general is rest, so night splinting or splinting full time of the wrist so that you don't work too much. That's one option. If you are not a diabetic, we do a injection of steroid cocktails into the wrist to decrease the inflammation of the surrounding muscles. And last but not least, we do a release. This is surgery again of the transverse carpal ligament, and that will relieve the pressure to the median nerve. Okay, the next thing that we're going to discuss, I want you to review the anatomy of the extensors and flexors into the phalanges in the hand. Why is this important? Because these are all problematic when you have boutonniere's deformity in the index finger or swan neck deformity of the other fingers with rheumatoid arthritis. So these are the two deformities associated with rheumatoid arthritis patients. Now, Froment sign, what is it? So this is a sign of ulnar nerve paralysis. When pinching a piece of paper between the thumb and index finger, the thumb IP joint or interphalangeal joint will flex if the ADP muscle or adductor pollicis muscle is weak. The papal benediction sign is again one of the signs that you will see in ulnar neuropathies. Now, there are actually, technically speaking, a papal benediction sign with ulnar and median nerve, but this is also called a claw hand. So the terms for this papal benediction or claw hand, this is common in ulnar nerve. Now, you can have injuries or basal thumb arthritis. That can be one of the causes of pain in the hand. Another common, and this will be seen in middle-aged patients commonly, is a stenosing tenosynovitis, also known as a trigger digit or trigger finger. So what is this like? This is a feeling that one finger gets left behind. That is a trigger finger. Okay, you see in this case, it was the middle finger that has stenosing tenosynovitis. And it's because of the A1 pulley that has a problem. There is usually a nodule and there's usually thickening of the A1 pulley caused by some sort of inflammation. So you have a combination of different pulleys in the flexor mechanism. A1, A2, B1, C1, C2. But you don't need to remember any of that except for the A1 pulley, because that's the first and most important pulley. And if you have carpal tunnel, if you have stenosing tenosynovitis or trigger finger, the first thing you want to think about are medical comorbids, endocrinopathies like diabetes, because you'd like to check your patient's sugar if they have this. And if they do have some diabetes or endocrinopathies, I would not recommend doing a trigger finger injection with steroids because it's usually only successful in 50% of cases. So in these cases, when you have diabetics with trigger finger, the first treatment is always physical therapy. And if rehab does not work, then that's the time where we go to surgery if they are diabetics. If they are not diabetics, then they have a higher success rate with steroid injections. So we do rehab first, number one. Number two, you can do steroids if they are not diabetics. And lastly, you can do your trigger finger release when all else fails. And when you have stage 4 of the trigger finger, when you cannot actually move that digit already. So these are the tendon pulleys: A1, A2, A3, C1, C2, C3, C4, C5. The most important again is the A1 pulley. This is the pulley that is released when you have trigger finger. Now, Decker veins tenosynovitis. Do you have it? That is the question that I give my students who are all doctors. If you're all the time writing down with your right hand, chances are a lot of you might have Decker veins. Okay, and this is how you test for Decker veins. You see that on the wrist, on the thenar side, that is your first extensor compartment. Okay, the first compartment composed of the extensor retinaculum has the abductor pollicis longus and extensor pollicis brevis. It also encases the superficial branch of the radial nerve. See that point right there? If you have pain in your wrist in that area, you may have a Decker veins tenosynovitis. How do we test this? The Finkelstein test. Okay, you can flex the thumb first and then place the wrist in ulnar deviation. If you find that you have pain on your wrist, then you may have a Decker veins tenosynovitis. You may need a little bit of rest. That's all you need. This is also associated with endocrinopathies like diabetes. And if you don't have it, then well and good. You are normal. Some patients also complain in the clinic of a rubbery lobulated swelling over the wrist or hand. This is usually a ganglion cyst. Now, a ganglion cyst is not like any tumor that is life-threatening. It's usually a lot of fluid-filled cysts on the dorsum of the hand or the wrist. And that is what a ganglion cyst is. We do have to remove it if the patient wants it removed, but at times, if you rest, you will find that the ganglion cysts actually grow smaller. They are associated with some trauma to the wrist or tendons, and that's the cause of why they increase in size. And the more you rest it, the more it decreases in size. Treatments include, number 1, rest. Number 2, injections with steroids. And number 3, surgery if the patient requires it. Now, bite wounds. Bite wounds can become an emergency. Why? Because if you think it's only the skin that's been bitten by the dog or human, you are wrong. Remember the anatomy of the hand. Underneath the skin, you have tendons, you have nerves, and because the tendons are rooted deeply and go into the wrist, into the forearm, the infection can spread very quickly. And in this case, you will see that the digits of the hand are like sausages, especially the very red erythematous middle finger. That is where the patient was bitten. So, review the anatomy of the hand. In this case, some patients who have been bitten for almost 2-3 weeks come into the emergency room, and those are the patients that may need surgery because they came in too late. Of course, it's not always necessary to do surgery. We are able to treat them with antibiotics if they come acutely within the first few days or maybe the first week. But if it's a patient who comes in after 2, 3, 4 weeks with a very erythematous hand and there's signs of pus already, we may need to do surgery. Here are other infections in the hand. This is on top, we have a felon, and that's where we incise and drain the pus. A paronychia There's also some pus. Both of them can be treated with antibiotics acutely, but if there's a lot of pus, we may need to drain it. An abscess always requires incision and drainage, no matter where it is in the hand, because bacteria can accumulate very quickly. And the dead bacteria can no longer be removed by antibiotics. This is an example of syndactyly, very common in pediatric patients. We do surgeries to remove the syndactyly. A little bit about trauma. This is a fall on outstretched hand that's usually the cause of traumas around the wrist. This is a collis fracture with a characteristic silver fork deformity with dorsal and proximal displacement of the distal fragment of the radius. Another case of a collis fracture, again, the dinner fork deformity is more pronounced in children because you can see that clearly. Some of them may need castings and some surgery. In this case, the patient was treated with 2 pins or K-wires. In this case, this patient was treated with open reduction and internal fixation. Remember that if a wrist bone has been fractured, you must always take into consideration the associated injuries possibly to the carpal bones, to the ligaments. So we cannot miss these things. We may need to get an MRI in some cases, but in general, you just need to get good x-ray views of the patient. For the hand, it's not just the AP and lateral. You may need an oblique view also. So here we have an AP view and an oblique view. This is a metacarpal fracture on the 4th metacarpal treated with, that's a K-wire, so that's open reduction pinning. Here is a distal phalanx fracture which was actually treated with, again, pinning. If your finger was hit by a ball directly, that can cause a mallet finger. You may need to rest and splint this digit. And that's all the time I have for hand surgery. I'll see. So just a disclaimer, this video is for educational purposes only. Please do not use my videos for treatment of your osteoporosis. Please see your healthcare provider and please stay safe.